Best way. I am. Studies program. So, on the real life challenging cases of clinical cardiology, particularly related to patients with CAD and PAD. And at the same time, today's we have two cases we are going to discuss. Specifically, the patient is going from AF to VTE to CAD, and second case is of COVID-19 cardiology. So today we are very glad today with us Dr. Praful Kirkar sir. He is our course director, and sir, welcome to program sir for our today's program. And Dr. Kirkar sir, he is former president of CSI from Mumbai chapter. He's the chairman of Board of Studies at Maharashtra University of Health Science. He's done many presentations in national and international meetings, including prestigious orations and awards. Several publications in national and international journals. He's also a CSI guidance document on acute MI-HF care during COVID. He's also a chairman of Pinnacle India Registry in collaboration with KCC. And he has also participated as a principal investigator in notable trials like Paradigm HF and Paradise MI and ODY, SSCY and outcomes, select, scored, impact, and etc. So welcome, sir. Welcome for the program. And our next, the moderator is Dr. Kamal Sharma, sir. Dr. Kamal Sharma, sir, is a senior interventional cardiologist from UN Mehta Institute of Cardiology from Ahmedabad. He has a vast experience in coronary angioplasty and stenting, valvoplasty, pacemakers, and pediatric interventions. He's also having a teaching cardiology at the BJ Medical College, awarded Excellence Teacher Award by Gujarat University. He's awarded 22 gold medal for academic excellence during medical studies. A prolific speaker in the field of cardiology and diabetology. He's a cardiologist who have cleared civil service exam in first attempt. Around 180 publications, authors of 8 books and many book chapters. So welcome, sir. Welcome for the program. And our next moderator is Dr. Sujal Shah. Dr. Sujal Shah is senior vascular surgeon from Indovas Hospital from Ahmedabad. He is a director of Dr. Ben's Clinic and a visiting consultant at SEAMS, SAL, Apollo, Sterling, and Sanjeevani Hospital. His area of interest in endovascular interventions and thoracic, abdominal, aortic aneurysm, and laparoscopic surgeries for vascular disease, etc. He's participated in various national and international conferences and workshops, various publications, national and international, several posters and papers presented at national conferences. So today's speaker is Dr. Sushil Kumar Tripathi. He's done MD in medicine and DM in cardiology. He's also done a fellowship in FESC and FACC. He's a director of cardiology and Arogyam Heart Clinic, Ashok Nagar, Kandivali. Welcome to Dr. Sushil Tripathi, sir, and he's going to take a case presentation on patient journey from BTE to CAD. Our next speaker is Dr. Kaushal Gandhi. He has done DNB in medicine and DNB in cardiology. He's a consultant interventional cardiologist from Paul's Cardiac Institute, Anand, Gujarat. He's going to take a session on a case of COVID-19 coagulopathy. Welcome, sir. Welcome for the program. So with this, I will hand over the sessions to our beloved Dr. Praful Kirkar, sir.
Yeah. Well, good evening to all viewers and a happy new year, because this is the first time I think we are meeting in the new year on the occasion of this symposium, very aptly called No Thrombosis. By no thrombosis, yes, everybody would ideally want to eliminate thrombosis and no thrombosis. But this particular symposium aims at gaining some knowledge on thrombosis, and not just by merely didactic lectures, but by way of having case-based scenarios. So good evening to you all viewers, and also good evening to my co-faculties, Dr. Kamal Sharma and Dr. Sujal Shah from Ahmedabad. No thrombosis. By two very dynamic speakers, yes, young speakers today, from one Dr. Kaushal Gandhi from Anand in Gujarat, and then we have our own, my KM alumnus, Dr. Sushil Tripathi, who is a very dynamic cardiologist from western suburbs in Mumbai. So welcome to you all. And as we were discussing, the idea of this symposium is to have real life challenging cases which entail thrombosis as the presentation. And we all understand today, it's been always a long battle as far as cardiologists are concerned when it comes to balancing the, meaning trying to eliminate thrombosis on the one side and to balance bleeding on the other side, and then having a predictable antithrombotic response from the molecule that you're using. And towards that end, we've all become pretty much, I would say, fairly good experts in the use of Noacks, which have virtually replaced warfarin today. And amongst the Noacks, again, thankfully, most of all these Noacks have now become off patent. And we have our own Indian pharma making these Noacks, especially amongst these Noacks, Rivaroxaban is a versatile Noack, which is across the spectrum besides the established indications of SPAF indication, that is stroke prevention and atrial fibrillation, as well as VTE indication. Besides that, we have an extended indication of Rivaroxaban also for coronary artery disease. And today we have very exciting talks, one related to COVID coagulopathy itself. That's another extended indication of Noacks, as we all know. Do we really know enough? We don't know enough. So let's see what challenges are there in the cases that are going to be presented today. I think in the order, first we would have Dr. Kaushal Gandhi, is it? Or Dr. Sushil Tripathi would come in first?
Yes, sir. I am here, sir.
I think,
for the presentation.
yeah.
Yes, sir.
Yeah, go ahead, Dr. Kaushal. Yeah. And I think Dr. Kamal Sharma, if he's around, he might want to add something before we get started, or we can come in later, whatever. Yeah.
Yes, sir.
I think
Dr.
we can
Kamal.
start, sir. Let them have the case presentation. I think you've given a wonderful background and importance of the Noacks in the current scenario and the concept of no versus no thrombosis. So I think we can roll with the case.
Yeah. Go ahead.
Sir, good evening, sir. Sir, myself, Dr. Kaushal Gandhi. So I am presenting a case of which is known as COVID-19 coagulopathy. Right. So here one patient comes to with me, 46-year-old male patient with no history of any comorbidities, weight around 70 kg, and patient had acute chest pains of 5 years of duration. Right. And ECG showed the ST elevation in inferior leads. There is no history of any fever or any cough or breathlessness or any history suggestive of this COVID-19, right? And echo showed the global hypokinesis and no distinct RWMA as of now, and EF was around 50%, right? The laboratory reports are okay, and I would treat it as a ST elevation MI and treated with the aspirin plus clopidogrel, right, and plus lies with tenecteplase. So STs are resolved within 2 hours, and chest pain is resolved in 2 hours, and saturation around 94 on room air. So it was successful thrombolysis, right? So ST is resolved and pain is resolved more than 50%, right? But what next? Within the 2 to 3 days, still patient had a low saturation, and on 5th day D dimer was 6. And there is no symptoms, and on discharge antithrombotic therapy, as I given that next slide, that patient would be discharged. Next slide. On Rivaroxaban 10 mg for 3 weeks and with dual antiplatelet therapy, right? So here we discussed that patient might be associated as treated as a COVID-19 coagulopathy, and coagulopathy is a manifest as elevated fibrinogen, elevated D dimer levels, and minimal change in PT, APTT, other parameters, minimal change in platelet count in early stages of infection. The disease severity is variably associated with PT time, INR, TT, thromboting time, and variably by a trend towards the shortened activated partial APTT, right? So increasing IL-6 levels are correlated with increased fibrinogen levels, and coagulopathy appears to be related to the severity of illness and resultant thromboinflammation and intrinsic viral activity. So here the rising D dimer level after the admission elicits the modes, multi-organ dysfunction, and overt disseminated intravascular coagulopathy, DIC. And it was noted around the 4th day after admission, right? And longer duration of hospital stay associated with increased D dimer level and development of sepsis physiology. The bleeding manifestations are not common despite the coagulopathy here. in COVID-19 associated coagulopathy patients. So my question and my message are that prognostic implication of D-dimer levels is elevated D-dimer levels slowly on going down is optimal scenario, and rising D-dimer levels during hospitalization may signal persistent inflammation and propagating intravascular coagulation. Right. So these are the prognostic implication of the D-dimer levels. And it was postulated that mechanism of coagulopathy, as we all know, that depending on the risk factors, right, as if patients have the acute illness, bedridden patients, right, the CKD, liver cirrhotic patient, COPD patient, heart failure patient, patient at malignancy, right, and there is a ongoing inflammatory response, endothelial dysfunction is ongoing, right? And second is hemostatic abnormalities like pulmonary microthromboembolism, the intravascular coagulopathy, myocardial injury, and increased cardiomyocytes. And all this together leads to clinical outcomes like VTE, venous thromboembolism, myocardial infarction or stroke, and DIC, right? So this is the postulated mechanism of coagulopathy and pathogenesis of thrombosis in COVID-19 coagulopathy. So what we can do best to the patients that should we discharge patient only on the antiplatelet therapy? Should we add the antithrombotic therapy? How can we add, for example, we can add subcutaneous injection BD doses or the Noacks. What is the ideal therapy? So anticoagulation treatment in COVID-19 is the keyword when the treating patient with 19. For example, dynamicity is there, and it should be low risk, intermediate risk, and high risk. We go ahead with the chart that coagulopathy in COVID-19 changes daily, right? And according to the chart, we first see the patient comes under the low risk, high risk, and intermediate risk of patients, right? So this is from the Society of Critical Care Medicine, SCCM. And according to these guidelines, the D-dimer level is normal, for example, normal, and there is no risk factor. No risk factors like patient is not liver cirrhotic or COPD or CLD or heart failure patient, bedridden patient, no any active acute illness, then there is no risk factors. Then there is no coagulation, anticoagulation required, and we encourage patient to stay active. Right. If this patient comes under the high risk patient, for example, D-dimer more than 2 times of the normal, and there is a bedridden patient, immobility of the patient. For example, patient had prior venous thromboembolism history, patient is taking any hormonal drug or whatever, patient had a BMI more than 30, history of any cancer, and there is no bleeding risk. For example, His-blood score is okay, no bleeding risk, then it is considered to be high risk. Right, minus slide, minus. Then it should be slide minus. Then this should be patient comes under the high risk category, and in high risk category we should be optimize the treatment. Like minus slide minus. So we should be optimize the
Go
treatment.
to the previous slide, please.
Previous slide. So treatment should be optimized for by giving the at least 6 weeks of therapy of Enoxaparin 40 mg daily, right? Then Apixaban or Rivaroxaban 10 mg daily. And patient should be followed 4 to 6 weeks to determine the need for any further anticoagulation therapy. So here we conclude low risk and high risk. And what should be treatment given in the intermediate risk of patient? For example, D-dimer is more than 2 times of normal, but no any risk factors. So there is no any risk factors, for example, immobility, prior history, or anything. Just D-dimer is elevated more than 2 times. Then we should consider aspirin daily and encourage the patient to stay active. So now we should decide the maximum use of the anticoagulation or whatever how to prevent the risk of thrombosis or how to prevent the risk of any coagulopathy related problems in the patient in different scenario of low risk, intermediate risk, and high risk patient. Right. Next slide. So it should be categorized by doing the D-dimer at the onset of or when the patient presents to our clinic, then detailed history of previous history of and patient and etc. Right. So here the antithrombotic therapy in COVID-19, a scenario position the study by the heart disease management program in the Tamil Nadu, that patient is divided into mild, moderate, and severe on the clinical presentation. For example, mild saturation is okay, there is no symptoms, right? The pneumonia is there, but there is no symptoms. Moderate is pneumonia is there, symptoms is there, saturation between 90 to 94, right? And severe presentation, saturation less than 90, and there is a rate is increased. Previous slide. So here, according to this Tamil Nadu case study, the patient is divided into clinical presentation. Previous slide, sir. Is presented to the and according to it, the antithrombotic therapy is divided. Previous slide, Sudhir sir. Sorry, so according to patient, it was divided in the again it should be Hazlitt score high or low, and venous thromboembolism score for in the past history, and according to it there is no anticoagulation or any prophylactic dose of the aspirin, or the treatment of with the Rivaroxaban is divided, right? So this is the busy slide with according to Tamil Nadu study, but we prefer the previous slide, that patient should be divided in low risk, intermediate risk, and high risk patients, right? Next slide is showing the study of the with the Rivaroxaban. Sir, next slide. This is the study of the Rivaroxaban versus Enoxaparin. Is the Magellan study, and in this study, the acutely ill medical patients, for example, it's shown that on day 10 and day 35, the Rivaroxaban was non-inferior to Enoxaparin is the standard duration thromboprophylaxis. So it's the composite primary efficacy endpoint, and p-value is only in the composite primary p-value is significant. Otherwise, rest of the asymptomatic proximal DVT, or the primary endpoints, the Rivaroxaban shown the non-inferior to Enoxaparin in prevention of the thromboembolism. The Magellan study. Next slide. So next slide. So here the one more study is the from the Mariner trial, which is published in JAC 2020. It is shown that Mariner study demonstrated that the efficacy of post-hospital Rivaroxaban use of preventing VT in medically ill patients, and there is a 28% reduction in fatal major thromboembolic event without a significant increase in major bleeding. So post-hospital discharge use of the Rivaroxaban, it was published in 2020 in JAC, that Mariner study showed the post-hospital Rivaroxaban use of the preventing VT, venous thromboembolism, in medically ill patients. So for example, patients presented with the bedridden, acute fever illness, and if fitted into this criteria, and we give the Rivaroxaban, there is a 28% reduction in fatal major thromboembolic events. Next slide. Next slide. So what is the known as the extended or post-discharge VT thromboprophylaxis? Although there is no data of specific COVID-19 exists, there is a reasonable to employ that individual risk of stratification for thrombotic or hemorrhagic risk, and followed by consideration of extended prophylaxis up to 30 to 45 days for patients with elevated VTE. For example, reduce elevated risk of the venous thromboembolism. For example, reduce mobility, more than 2 or more comorbidity, and active cancer, and elevated D-dimer level of more than 3 times, right? Then who have the low risk bleeding. So these all the patients are coming into the criteria for the extended post-discharge extended use of the Rivaroxaban use. And here again, the Noacks Rivaroxaban 10 mg OD will be preferred over the other Noacks, because the studies are available, right? And there is a good coherence with the fixed dose oral drugs. There is no need of any NR monitoring, and improved compliance due to the fixed OD doses, once OD doses. Next slide. So here we discuss the extended use or post-discharge use of the Rivaroxaban. right? And specifically, it was used in my patient, for example, after the MI, and there is a suspected COVID-19 infection or any COVID-19 infection with the patient is bedridden and the patient had more than 2 or more comorbidities, and there is a more than 2 times more D-dimer level, then it should be fall in the high risk category, and we should use the extended use of up to the 45 days of Rivaroxaban to the patient.
Kaushal sir, you are on mute, sir. Please unmute, sir.
Just I unmute myself for it. Yes. So, sir, the common scenario, Kamal sir, what kind of common scenario at present in clinics and etc., sir?
So that's a very interesting case that you have put forth. I think there is no anatomy studied here, right? It's just that ST elevations, acute, hyperacute anterior MI in a patient with no risk factors and incidentally detected to have RT-PCR positive and the D-dimers elevated during the stay in the hospital. So firstly, now etiology-wise, are we justified in saying that this is a COVID-related arterial thrombosis? That's the only thing. That's only clinical that we have over here. And he is not symptomatic COVID, right? Though his saturations were 94% or something like that. Right. And they remain. So what was his COVID pneumonia status like? That's what is thing that would come to our mind. Do we have a proper COVID pneumonia as such, or is there any CT or an X-ray chest or anything like that? See, because the issue is here primarily, can this be that the COVID here was an innocent bystander, that the whole world is getting tested to be RT-PCR positive, though he did not come from a red zone, etc. Suppose he's got the bug, but whether this was a prothrombotic state itself, what kind of an MI was this? Those will be the points that will come in, right? So what do you have to, Dr. Kamal, you have any views on this? Go ahead.
Yeah, I think your points are valid. Another thing is that a lot of patients with COVID pneumonia come with type 2 myocardial infarction. They actually have no obstruction and you have still elevation. I think I've discussed in previous no thrombosis episodes as well. I had a young guy, 22-year-old, coming with an acute MI, ST elevation, troponin positive, post 3 days of vaccination actually. And then RT-PCR also positive. So we don't know which one of the two was culprit. And this patient also had vomiting, nausea, central chest pain, perspiration, went to one of the leading cardiologists of Ahmedabad city. He said, you need an angiogram. He wanted a second opinion, came to me. I said, you need to, because there is no other way I can confirm it or rule it out. And the other option is that you get a CT angio and then we proceed. Otherwise, absolutely stable, day 3. And then he agreed for an invasive angiogram. And I remember doing an angiogram and I said, angio is normal. This guy stood up in the cath lab table and said, thank you, doctor, where are you? So he had absolutely flowing normal coronaries. And this was classical example, good 4 millimeters inferior ST elevation. So I think your point is pretty much valid, what Dr. Kelkar is trying to say, and angiographic anatomical correlation would have been important. But yes, either of the case, maybe Rivaroxaban would still hold a place, because even if you have a type 2, with D-dimer elevated more than twice, as the algorithm that you showed, you were justified with twice the D-dimer to give a Rivaroxaban. There's no doubt about it. But remember, that is not therapeutic from the perspective of acute coronary syndrome. You have no evidence for treating ACS with Rivaroxaban in this scenario. But yes, a D-dimer elevation, prothrombotic milieu, if that is something that you're looking at, and then justifying it as an additional risk factor, why this patient should have been on a Noack, I mean, that is point well taken. But as sir is saying, maybe a CT angio if he was not willing for an invasive angio to define the anatomy, pure thrombus, no thrombus, type 1, type 2.
The thing is that atherosclerosis itself, and atherosclerotic coronary artery disease itself, could get aggravated also during COVID times. That is also very well known. So for understanding whether this is an underlying ASCVD which is presented during COVID times versus as what young age, in Dr. Kamal's case, it was 22 something. Now yours is a 40 something patient, right? But he doesn't have any risk factors. That is what brings to light whether it's just a prothrombotic state and whether it's a type 2 MI after all. So having said that, let us further, just for the sake of discussion, let's bring in the coronary artery disease indication also for a Rivaroxaban itself. Now, say this was just an ACS, okay? So then what kind of, now the dosing again, here based on the Magellan study and whatever studies that you talked about, or Michelle, etc., post-discharge thromboprophylaxis wise, Rivaroxaban 10 milligram OD is a very popular dose, and there are enough studies towards that end. But otherwise, say it was just a atherosclerotic coronary artery disease wise, and then whether there is any role to give on top of dual antiplatelet a vascular dose of Rivaroxaban, if at all. That's the point that comes to our mind. And for that, there is no real indication as such. Now, empirically, some people might give it basis that there is a lot of thrombosis there. Okay. But otherwise, for ACS as such, no. For extended thromboprophylaxis, after having had your initial stenting or whatever you've done for the ACS event, then anywhere after 1 year for extended antithrombotic therapy, that's when that Rivaroxaban 2.5 milligram BID dose would come in. Now that, let us presume that your patient, like Dr. Kamal Sharma's patient, was also a prothrombotic state that caused it all. Then how long and what kind of a therapy in the context that it is also coronary artery disease? So how long would one want to, there are no guidelines as such telling us how long would we want a triple antithrombotic therapy on this patient. So it's different when you are in an AFib scenario, also meaning doing a PCI, then we know as early as within 1 week we can withdraw it and just be on a P2Y12 inhibitor, invariably clopidogrel, along with a Rivaroxaban or whatever the Noack you have chosen. That's fine. So what is your take, Dr. Kamal? In such a scenario, how long would you want to give the add-on Rivaroxaban in addition to the usual dual antiplatelet therapy, which you would have any which case received just the basis that there was an ST elevation MI just in the inferior leads? Though he was saying that echo-wise there was no regional wall, it was all global hypokinesia is all what he noticed. How long would we want to give and in what dose Rivaroxaban in addition to on top of dual antiplatelet in such a scenario?
I think, we don't have much of an evidence in such a scenario. Whatever evidence we have is when you are dealing with a case where you have AFib and you're doing a PCI, or you have small data where they've looked at in terms of low dose of Rivaroxaban, as you are talking about the 2.5 BD. With anecdotal case, and you can look at and extrapolate in terms of Atlas TIMI data. But I think overall, probably we don't have data to think of 10 milligrams per se as a therapy in aspirin and clopidogrel in an ACS where you don't know the coronary anatomy. So that is slightly dicey to choose. But even if you end up giving it, the dosing of 10 milligrams would be that for the DVT prophylaxis, which the classical dosing is for 21 days to 28 days. Some studies talk about 6 weeks, but I don't think that would be a case here unless. So again, global is again going to tell you, maybe it's a Takotsubo. We have reported Takotsubo and reverse Takotsubo in COVID-19. We have our own case report and even case series of Takotsubo in COVID-19, where you can get all these kind of ST elevations, global, LV dysfunction or reverse Takotsubo kind of a pattern, and patient actually has a normal coronary. So really, anatomy would have really added a lot of things to it. But I think if we were starting this therapy beyond a month, surely not the 3 drugs. I mean, I'll either take off aspirin at least, or if not anything, at least the Rivaroxaban.
Even say he was a COVID pneumonia admitted, then also post-discharge prophylaxis, thromboprophylaxis that you want to give going up to 31 to 39 days, whatever the kind of trials that we spoke about. Even there was that Michelle trial also, right? Where they gave it to non-critically ill patients, but yet they gave it and then they showed some benefit there, though that was an open label trial and leaves a lot of criticism because small data again. So that 10 milligram OD, the primary premise on which you give it is that there is no high bleeding risk. Now, this patient, though he doesn't have features of high bleeding risk otherwise, history-wise, he is high bleeding risk by virtue of being on a dual antiplatelet, isn't it? So it's not like we are treating as COVID as a post-discharge thromboprophylaxis given for 10 milligram OD. The question here will be still empiricism as to how long you want to give it, taking it from the AFib scenario, where we might be able to drop it as early as within a week. Those are elderly patients, AFib patients, and all. We drop it as early as 1 week. It will still be empiricism as to when do you want to drop aspirin in this patient. Again, having said that, aspirin is plus minus benefit for COVID pneumonias as such, isn't it? And there is enough data to say that aspirin has no role there. So the question here is, even if we tend to give 10 milligram OD, then when do we want to drop the aspirin in this patient also becomes important. Just that you want to be on a clopidogrel along with Rivaroxaban. I would rather drop aspirin after a week or so in this patient for sure. We're not knowing the anatomy.
Yeah, without knowing the anatomy, right?
Yeah, because even for atherosclerotic coronary artery disease, where we have stented a patient, we are happy to drop aspirin. To this patient, so definitely I'll drop aspirin. From pure COVID perspective, he's on a good dose of 10 milligram OD of Rivaroxaban, but I would just keep him on a second antiplatelet if at all. That's about it, isn't it? It's all empiricism as to how you would go about it. What Dr. Sushil Tripathi is also there. He's going to discuss from VTE to this. Sushil, do you want to add anything to this as to what Dr. Kamal has been saying, or Dr. Kaushal has been saying?
Very good evening, sir. And I think it's a very good discussion. We have in-depth discussion on VT prophylaxis with Rivaroxaban. And as you rightly said, if you have dual antiplatelet addition, it will definitely increase the risk of bleeding. So I think vascular doses in such cases will increase the chances of bleeding. And we should continue with, if we have documented evidence of increased VT, then only we should give the vascular doses, otherwise not required.
Okay. So that's a very interesting scenario. Now, having said that, just because we want to discuss COVID pneumonia and because Rivaroxaban 10 milligram OD is such a popular dose, is it meant only for, what is important is that it is meant only for hospitalized patients post-discharge, isn't it? What about this same D-dimer scenario? This patient got hospitalized because of his MI as such. He's got borderline saturation 94 types. He doesn't really qualify otherwise for hospitalization except with that MI. Say he was an outpatient and the same kind of D-dimers, for whatever reason, it is not required to do D-dimers, and you did it all. And then you were to give him. So is it justifiable to, firstly, on an outpatient basis, to give Rivaroxaban 10 milligram OD? Where are we? Because we still 2 years down the line after the pandemic has taken, thankfully the prothrombotic states have come down with this Omicron wave that we've got now. But are we justified in giving Rivaroxaban for outpatient care? Is my
right. So anyway, sir, 10 milligrams is not an
faculty.
arterial dose. That is what we say. I mean, 10 milligram is mainly for the venous thromboembolism as a prophylaxis that we give. So even if it is on outpatient basis and it is suppose a MI situation, I would not like to add just 10 milligram in addition to dual antiplatelet and the standard of care.
No, I'm not talking about this particular case. I'm talking about besides the arterial thrombosis that this patient has, which we do not know the etiology as such. Say for a COVID pneumonia, if a patient is to be treated at home only, that COVID pneumonia means he's got the usual COVID bug and not got. But would there be a role at all for Rivaroxaban for somebody on an outpatient basis management? 10 milligram OD management, so to say. Or for that matter, people get admitted now for an antibody cocktail and then get discharged. Is there any, are we justified in giving a Rivaroxaban 10 milligram OD, or for that matter, any other Noack 10 milligram OD at discharge? As of now, at least the guidelines don't suggest it, is what I'm trying to say. It is not my practice, at least, to give for all COVID patients as such.
Absolutely, sir.
Is there anything else, Dr. Kamal, you would like to add or subtract from what we've discussed so far? Or?
No, I think perfect. So I think Dr. Tripathi's point is also valid. I mean, looking at the vascular dosaging, you're looking at the arterial bed versus the venous bed. the dosaging that you would look at in terms of 2.5 BD, say, or 10 milligrams. I think Dr. Kushal was justified in using 10 because he was chasing at a venous thrombotic milieu as well. This patient had D dimers that were rising definitely more than twice the value. And he was a high risk patient, assuming that he had a thrombotic milieu in terms of maybe even if it's a type 2 MI or maybe it's a type 1 MI. Either way, he's a prothrombotic milieu. And because 2.5 BD is not going to take care of your vascular thrombotic milieu, so probably that way, logically applying it using a 10 milligram is still okay, rather than risking yourself with 2.5 BD.
Okay. So let's move on with Dr. Sushil's case. Yeah. So talking about COVID and all, recently Sushil is an alumnus of KEM, not because of that I'm trying to say, but recently he brought to light for us a very interesting case where he got caught into, where he was called in to evaluate in view of cardiomegaly. Was it a patient who was being treated as a COVID patient, though being COVID negative, and just a stethoscope on the chest wall, he was able to pick up a continuous murmur, and lo and behold, it was a sinus of Valsalva aneurysm rupture acutely, which got referred to us, and we fixed it just last week. That was that was an interesting one. Yeah.
Go ahead. That was excellent management, sir. So good evening to all my teachers. PGK sir, my teacher, my mentor, was taught me ABC of cardiology, and giving a lecture on this platform under his moderation is a dream come true for me. So today we'll be just discussing, we all know basically the role of Rivaroxaban in thrombosis, specifically from VT to coronary artery disease and to non-valvular AF. So I think venous part has already been discussed in detail. We'll just touch the non-valvular AF indications and management, and where do we currently stand in terms of anticoagulation with the availability of more and more Noacks up to Enoxaparin. So just quickly just brush up the important benefits of Noacks over vitamin K antagonists. We all know it has a fast onset of action, so we need not wait for 3 to 5 days as we traditionally would have done when there are VKs. There is a predictable anticoagulation. No need to do INR monitoring and reduced potential for food and drug interaction. No food and drug interaction. No need for the INR monitoring, and simplified and fixed dosing regimen for all the patients, those who are indicated. Next slide, please. So if you just quickly brush up with the pharmacological profile of various Noacks. So Rivaroxaban is the one with the highest oral bioavailability with approximately 80%, and the renal clearance is around 33%, and no major drug-to-drug interaction compared to all other Noacks available. It has the highest oral bioavailability, and that is probably not a reason for it being a OD doses, but still it is given in the once in a day formulation. Next slide, please. Yeah, next, please. Yeah. And many times we are confronted with a bleeding profile with many of the Noacks, and traditionally it's not the parameters how we measure the anticoagulation activity of the various Noacks. So for Rivaroxaban and Apixaban, it's a measurement of anti-10A assay that will define. And with Dabigatran, we can either use APTT also or other parameters, but not the anti-10A activity. Next slide, please. So if we see the history of anticoagulants so far, and it all began in the 40s and 50s when we started using the vitamin K antagonists, followed by a low molecular weight heparin, and then the development of injectable anticoagulants in the form of fondaparinux and low molecular weight heparin, followed by, in last almost 1 decade, development of various Noacks from Apixaban to Rivaroxaban to Enoxaparin, and many other to come. Next slide, please. So I'll be focusing my discussion on non-valvular AF, and we all know the guidelines right now say any patients who is having atrial fibrillation, either being diagnosed on ECG, or many times we recommend for a Holter monitoring, on which we just catch up the atrial fibrillation. And after that, it is routinely recommended to do a CHADS2-VASc scoring to find out the risk factor for the development of stroke. And if CHADS2-VASc score is more than 2, all the patients require some or other form of anticoagulation. And from 0 to 1, yes, we can accept and just monitor the patient and may not require anticoagulation. Next slide, please. So if the dosing, as far as the dosing goes, the Rivaroxaban, the standard dose is 20 milligram once in a day. Apixaban 5 milligram BID and dabigatran 150 milligram BID. The low dose regimen is 15 milligram once in a day. Apixaban 2.5 milligram twice a day, and the dabigatran 110 milligram twice a day. So the low dose is specifically for the patients with creat clearance, for example, 15 to 50. If with Rivaroxaban, we'll give 15 milligram once in a day. With Apixaban, the ABC criteria we follow, that is age more than 80 years, body weight less than 60 kg, and creatinine more than 1.5. In such group of patients, we give 2.5 milligram BID, and the dabigatran, if the risk of CNS bleeding is more, we will still stick to the 110 milligram BID. Otherwise, 150 milligram BD is the dose which is found to be superior to vitamin K antagonist compared to warfarin. In such patients, we give 150 milligram BD, otherwise 110 milligram BD. Many of the Indian companies are there with 75 milligram, but none of the guidelines indicates that we need to give 75 milligram BID, and which is equivalent to vitamin K antagonist for the prevention of stroke. Next slide, please. So if you see the various Noacks and their major landmark trials and distribution of CHADS2-VASc scoring. For example, if we see the Rocket AF trial, which was head-to-head comparison of Rivaroxaban with warfarin in those patients, and the Aristotle, that is Apixaban compared with warfarin, but patients with high CHADS2-VASc score were there in the Rocket AF trial. Almost 87% of the patient had score of more than 2. So as we all know, the higher the CHADS-VASc score, the higher the risk of bleeding parameters also, because the has bled parameters are also proportionately increasing. So these were the group of patients who were at the risk of stroke, and therefore they required anticoagulation, but at the same time are also at the risk of bleeding also. But in such a larger proportion of population of patients where they have high CHADS2-VASc score, but still the outcome in the form of stroke and systemic embolism were comparable with other Noacks. So I think Rivaroxaban overscores in such regard to all other Noacks available. Next slide, please. This is in nutshell the Noacks versus warfarin, the trial summary, that is dabigatran, Rocket AF, Aristotle, and Enoxaparin. As I discussed earlier, the risk of stroke and systemic embolism was comparable to warfarin, and intracranial hemorrhage, interestingly, was low in Rivaroxaban and Enoxaparin and Apixaban group compared to dabigatran. And all had enough number of cases, but as I said, the number of high-risk patients with high CHADS-VASc score were there in the Rocket AF trial, where Rivaroxaban was compared with warfarin. Next slide, please. So to summarize the guidelines for the use of Noacks for the non-valvular AF, so all available Noacks in India, dabigatran, Enoxaparin, Apixaban, can be used in their recommended doses with a creat clearance of around 50, and less than 50 they require modification. Up to 15 ml per minute of creat clearance they can be given with the reduced dosage, which I just discussed, and less than 15. Though Apixaban has recently been tested that it can be used in patients, but otherwise less than 15 patients who are on dialysis, in those group of patients, Noacks are contraindicated, and other measures like heparin can be used. Next slide, please. So again, this is just a summary of various Noacks available for the prevention of non-valvular AF. and we have already discussed their dosage, their modification in patients with different creatinine clearance. And the only Noack that is tested prospectively for the specific renal dose was Rivaroxaban with 15 milligram once in a day, more than 15 ml per minute of creatinine clearance up to 50. Next slide. Thank you, sir.
Well, thank you, Sushil. That was an excellent overview of the Noacks and their pros and cons of each Noack over the other. So especially what comes to mind is that Noacks, yes, meaning the greatest touted benefit of Noack is that there is a predictive, that you do not need monitoring. Yes, you don't need monitoring as far as the blood coagulation parameters are required, but all of them are renally excreted eventually. And you do need to especially be careful about the kidney issues, and especially in a country like ours where you've got a hot, humid climate, especially cities like Mumbai and even Gujarat for that matter. What is your Noack of choice, and how do you go about for renal dysfunction with Noacks? That is very important. We did mention the fact about creatinine clearance is what one would look at, and you mentioned about ABC for Apixaban. So which are the ones with Noacks that would be preferred with a patient with moderate renal dysfunction as such? Does anybody score over the other or anything like that? Yeah.
Sir, as such, I mean, all are being tested in the major trials with different levels of renal dysfunction, and up to, as I said, at least 30 creatinine clearance, we are very confident of less risk of bleeding. But at the same time, I mean, available there will, if there is a risk of bleeding or if patients have some major bleeding, for example, intracranial hemorrhage, I would like to use some Noacks where some kind of reversal agent availability will define. For example, if patient is at high risk of bleeding, already maybe with anemia, hypertension, and CKD, I would be reluctant to use a Noack which has no reversing agent available. For example, dabigatran, we have a reversal agent available, and then with Rivaroxaban or Apixaban, we are hardly anything other than FFP that we can give at least in major hospitals.
So where bleeding risk is high, and maybe even renal dysfunction is one of the reasons why there could be a high bleeding risk, and therefore you would prefer where you have a problem about bleeding as an issue, somebody that has got a reversal agent would be of benefit. But otherwise, for renal dysfunction as such, 80% renal elimination of dabigatran, that is the one molecule that I will never prefer in a renal dysfunction scenario, is because of the fact that at least pharmacologically, it has got 80% renal clearance. Less than 30 was a contraindication in dabigatran. And with going down to in the borderline range of 30 and 15 to 30 ml creatinine clearance wise, I think Apixaban as well as Rivaroxaban clearly score over dabigatran for renal dysfunction specifically, I would say so. Yeah. Well, Dr. Kaushal, you have to add anything to it, or we can have Dr. Kamal Sharma coming on board.
Sure, sir. Apixaban would be preferred choice among the three, my perspective.
Apixaban you would prefer,
yes,
for a renal dysfunction. Yeah, even Rivaroxaban for that matter, there is good data about it. Very important is that Noacks versus versus vitamin K antagonist as such. The general feeling was that when there is renal dysfunction, we would rather go back to good old warfarin. But that's not the case. There is even data coming up to show that renal dysfunction on warfarin therapy over a period of time compared to the Noacks would actually progress. Real world data also coming. And there is a progressive renal dysfunction that has been shown to occur with vitamin K antagonists like warfarin. And Noacks would still, with renal dysfunction, we should be still happy to use Noacks, and preferably, like what you very correctly said, Apixaban you might prefer, or even Rivaroxaban for that matter. That is the preferred Noack in that scenario.
सर अभी सर जो आपने बताया ना, वो ऐसा आ जाएगा कि डिगॉक्सिन हम कब यूज करते हैं, मतलब ओनली टू इंडिकेशन, AF विथ लो इजेक्शन फ्रैक्शन, राइट? तो मतलब ये रियल वर्ल्ड सिनेरियो यूज करते करते आ जाएगा कि वारफेरिन नहीं करना है, यही करना है यूज.
Yeah, that's quite possible. You're right. Meaning that is what. So Noacks in renal dysfunction, we should not hesitate about. But having said that, what I'm only trying to impress upon our viewers here is that monitoring is not required. In fact, as your renal dysfunction progresses, you require greater monitoring. And that monitoring may not be of the anticoagulation itself, but you may not have to require to do PTs and INRs and all like what we do in warfarin. But the very important thing is that we need to monitor renal dysfunction on Noacks is the message that I wanted to just convey. Well, that's been an excellent presentations. Both of you have done a great job. Thank you so much. I don't know if Dr. Kamal Sharma, he was supposed to have joined, according to Ravi, had messaged me saying that, oh, we are fortunate to still have you've not gone into another symposium.
Yeah, I need to.
So would you want to give some parting words as to how would you compare one Noack? Of course, we cannot do any head-to-head comparison given that there is no such trial, right? But dissecting out these trials, where would you pick on one versus the other? Or GI bleeding now, for instance. Let's discuss GI bleeding. What do you think?
Yeah, I think the real-world evidence is predominantly, even from the Atlas TIMI, we know that the GI bleeds were more common with the Rivaroxaban. And now that people are talking about that, it actually brings out a hidden or occult malignancy. It's rather, a flag sign to tell you about a hidden malignancy which you otherwise would not have picked up had you not put the patient on Rivaroxaban. So maybe that's the other extreme of arguing for it. But I think I tell my patients, I mean, you bled from GI tract, you didn't bleed from the your nose or ears is because you have some pathology in your GI tract. So if your taps are leaking, the problem is not with the water, problem is with the tap. So you need to fix the tap rather than blame the water that so it's not the blood thinner, but it's the site from where it is coming. And I think from GI bleed, probably that's the way. And for the ICH, it is dabigatran. We know that again, that the IC bleeds in 150 are surely more than the warfarin in the 150, but then the advantages of infarcts far supersedes the ICH. And that's why you have a superiority data of dabigatran and Rely trial for 150. You have safety data for 110. You have lesser bleeds, but equal stroke rate in Rely at 110. So I think if you have ICH or CV intracranial issues, then avoid dabigatran. If you have GI issues, then avoid Rivaroxaban. People claim apixaban is as safe as aspirin and as potent as warfarin. But remember, that's non-superior. That, I mean, it's potent as warfarin means the Aristotle talked about equality in terms of the CV events, but the lesser bleeding rates. And that's how the overall event rates were reduced in the trial for apixaban. So I think I'll be going probably with the widening indication. I would still be tempted to use more of Rivaroxaban unless I have a compelling GI bleed indication, because 10 milligram will surely have some benefit in terms of vascular protection on both the arms, which evidence we actually don't have for the other two. So that's my take.
So since we were discussing bleeding, what a point that Dr. Kaushal made during his presentation about look at both the Hasbled score as well as the high thrombotic risk score wherever you use antithrombotics here, right? So having said that, Hasbled score does not contraindicate for a SPAF indication. By SPAF, I mean stroke prevention and atrial fibrillation. It does not contraindicate a NOAC or a DOAC. It's just that higher the Hasbled score, the higher the thrombotic risk of that patient also, and we wouldn't hesitate. But having said that, for the Rivaroxaban vascular dose, which is one of the versatilities of Rivaroxaban as compared to the other two molecules that we were discussing, apixaban and dabigatran, they do not have any role for chronic coronary artery disease with high thrombotic risk. That's when Rivaroxaban 2.5 BID dose comes in, and that's a very dose which is underutilized. We are happy to use dual antiplatelet drugs without really that kind of a benefit. But here the benefit that we get with a 2.5 milligram BID dose as extended antithrombotic therapy post the 1 year of the event, post 1 year after ACS, or one would say post 1 year after a stenting procedure, we should be willing and looking for such patients. So in that scenario, Dr. Kamal, which are the patients which you would target for 2.5 milligram BID dose for that particular indication of Rivaroxaban?
2.5 would surely go for the CCS group, which is not the acute subgroup, and they would be polyvasculopath, as they call the enrichment criteria. You have patients with PVD, you have patients with stroke, you have CKD, or patients with chronic diabetes with multiple revasc with family history. Those are the subgroup will surely get a CCS indication where I would be putting my patients on 2.5. And I think it's a very vast subgroup.
again, a renal dysfunction is also
CRF,
likely
yes.
to benefit there. So
Yes.
the thing is that when we are happy to have combination therapies of dual antiplatelet are available in this country, left and right, especially with the clopidogrel. So the bleeding risk, importantly, is not any higher, okay, if at all. In fact, compared to ticagrelor plus aspirin, aspirin low dose, that is 75 plus 2.5 milligram BID of Rivaroxaban, actually has got a lesser bleed in that particular COMPASS trial. So the COMPASS indication, one should not forget as far as versatility of Rivaroxaban is concerned. So having touched upon a lot of thrombotic scenarios, I think it's time to say bye-bye to people, right? We have exceeded the time, and Dr. Kamal Sharma also wants to be going to Dr. Ravi. Mr. Ravi mentioned that he wants to join into another symposium also. Unless our young speakers for today, the both of them shown some excellent cases, and there was a great discussion. Dr. Sushil or Dr. Kaushal, do you want to add something to what we've already said? You could go ahead So over to you, Ravi. Over to you, Ravi.
Thank you, sir. It was really a nice discussion.
Thank you. I'll take your leave, sir. Then thank you.
Yeah, you have to carry on.
Thank you. Bye-bye.
Bye, sir. Thank you. I really thank to Kamal sir also, because Kamal sir was really busy. He was actually attending 2 seminars at a time. So thank you for Kamal sir also, and thank you for excellent presentation by Dr. Kaushal Gandhi and Dr. Sushil Patel sir. And as always, Professor, always thankful to you, sir, because your discussion and your value addition, it really makes a lot of difference. And actually, I can see, because more number of our delegates, today also we can see almost 364 registrations happened, and almost 340 logins has been. So across almost the waste stream, there are good numbers of doctors. They really want to listen to you, sir. And, thank you, sir. Thank you so much for participating. And before we will end, I think we will show our Exafib video and then we will close it, sir. With your permission.
Thank you so much. Yeah.
Yes, sir.
Do you know which Indian pharma company has consistently launched innovative first in India products? Presenting Emcure Pharmaceuticals. With over 500 scientists, we are pioneers in chirality. We have been making a healthy difference to countless families. With cardiology at our heart, we have strived to give you better products always. Chiral products are complex to develop. They are difficult to manufacture, but their benefits make a difference. A difference for your patients, for you. We are proud to launch our latest chiral development, Exafib, our indigenously developed Rivaroxaban. Developed in-house, manufactured at our state-of-the-art facility at Jammu. This is a WHO GMP certified facility. We conduct quality checks to ensure only the best is delivered. Exafib complements our chiral cardio portfolio. Exafib, committed to make a difference in anticoagulation therapy for your patients.
We have completed 1 year for Exafib, and since from 1 year, Exafib is #1 brand. So we are very thankful to all our prescribers.